All right. Afternoon, everyone. I'm Chris Schuler. I'll be giving a talk today on clinical decision support on FHIR. I've been involved in CDS implementation for the past 4 years with a company called Dynamic Content Group. We have implemented several CDS, including the CDC opioid prescribing guidelines, as well as converting measures to CDS and various other things. So yeah, let's just get going. All right, so what is clinical decision support? It's a good first start, right? So we got a nice little sentence there that kind of encapsulates it. To go further into that, it provides clinicians, staff, patients, other individuals with knowledge and person-specific information intelligently filtered or presented at appropriate times to enhance health and healthcare. Right? CDS encompasses several tools to enhance decision-making in the clinical workflow. These tools include computerized alerts, reminders to care providers and patients, clinical guidelines, condition-specific order sets, diagnostic reports, so on and so forth. It has a lot of use cases. So there are 3 basic components to CDS. The first is the information recipients. So these would include your patients, clinicians, and others involved. The next would be information delivered. This would be the guidance or suggestions that you would get back from the CDS service. And then the information delivery formats, which can be basically anything, really. Like in CDS Hook's world, that would be a CDS card. We're actually experimenting with others, dealing with questionnaire response exclusively, particularly in developing countries. And if time permitting, maybe we'll discuss that use case a little further. And in addition, there's various types of CDS, right? We have like our drug-to-drug interactions. So in the CDC opioid guidelines, there's a recommendation number 7 that says, it's not good practice to prescribe opioids and benzodiazepines concurrently, right? So we would get back a suggestion telling us not to do that. And then we also have drug allergy interactions. This could be, basically an allergy a patient has to an ingredient within a drug, anything like that. You have dose range checking. This could be, with the CDC opioid guidelines again. This would be for the morphine milligram equivalency to make sure it falls within a certain range of best practice. We have standardized evidence order sets, links to knowledge references, links to local policies, alerts, documentation templates, relevant. it goes on and on. This isn't an exhaustive list, just an example of a few things CDS can tackle. And then let's get into the benefits of CDS. So the main benefit is quality, right? We want to guide users to best practices and reduce errors. And the best way to do that is to provide a care team with consistent, reliable information, right? And the main aspect of that is efficiency. We want to ease the information overload that clinicians typically face these days, right? There's just so many best practices, so many guidelines, it's near impossible for any one man or woman to tackle all those. So CDS is quite valuable in today's healthcare as it expedites informed decision-making. Right? And that gets to the problems with CDS currently, which is a long lag time, right? And the reasons for this long lag time are inconsistencies. I don't know if anybody here has played the telephone game before when they're in elementary school. Is when the teacher would sit the students around in a circle and whisper a phrase to the first student, and then they would pass along that phrase to the next student. And by the time it got all the way around, the last student would stand up and say the phrase, and it would typically just be wildly different than what it started with, right? And that's how it works today when we're implementing CDS across multiple sites and multiple providers, is they're each translating the guidelines differently. And then it could even be that someone will take that translation that one provider's done that maybe has translation errors and then propagate those errors into their translations and maybe add in a few more, right? And then it just compounds the situation even more. And this is due to a lack of common standards, right? We don't have a common metadata model. We don't have a common data model. We don't have a common expression language model, right? And this just leads to just wildly different implementations across sites. And the consequence of this is an average of 17 years to get scientific evidence to apply in patient care. And so that's the real crux of the issue that we want to solve with FHIR. And in addition, there's also several implementation challenges, right? Chief among them being speed. The ideal response time for a CDS service would be in the order of about half a second, right? You want that information back quickly and as fast as possible, so we don't slow down the provider to the point where it's not beneficial anymore. It just takes too long. Maybe they don't even do it. They just bypass it, skip it. I don't want to wait 10 minutes just to get back a service call. So, and the second is usability and workflow. And CDS interventions can be disruptive and distracting, right? Well-designed CDS fits well into the workflow and does not disrupt unless absolutely necessary. And that gets to the next point, is that we want to avoid over-alerting, right? We don't want to cause alert fatigue to clinicians where they're constantly getting pop-ups every time they're in their workflow, and they're dealing with 20 to 30 different pop-ups, and they'll just end up ignoring half of them or all of them and maybe missing some important guidance. And another is leadership backing, and that has 3 prongs in it, which is cultural change, which it's important to build a case for the potential disruption caused by a change in the workflow or responsibilities, as well as management backing, which is needed to provide support for the staff who experience the potential disruption caused by some necessary CDS. And we need clinical leadership backing, which is to create the vision that this is about quality, so it is embraced by the staff and not seen as cookie cutter medicine or just another way they're trying to control us, something like that. Right? So now let's get into CDS on FHIR and how we plan to tackle that. And we're doing that with the FHIR Clinical Reasoning Module. And this was first implemented to harmonize CQM standards, clinical quality measure standards, with clinical decision support standards, and provide common metadata standards, common data model standards, and a common expression language model. So this allows decision support content to be shared as FHIR resources, right? Artifacts that define the structure of content, including rules, order sets, protocols, and questionnaires, and libraries that define the behavior using logic in clinical quality language, or CQL. So the key resources in sharing clinical decision support include value sets, which are a list of codes or concepts associated with a code system or code systems, along with a library, which is a container for the expression logic, or CQL. And this can also be used to package the logic and share it, as well as activity definitions to describe the recommended actions. So a recommended action may be to create a prescription, and an activity definition provides the ability to do that. And then we also have the plan definition, which describes the rules or the conditions that need to be met in order to run a CDS service. And then they outline the actions that need to be taken in order to bring that guideline or suggestion to fruition. Right? And the way FHIR is basically doing that now is through CDS hooks, which is a hook-based pattern for invoking clinical decision support. And a hook is just a concept that defines what information is required by the CDS service and when to trigger in the workflow. Right, and the CDS hooks specification describes the RESTful APIs and interactions to integrate CDS between CDS clients and CDS services. Right. And this is a basic overview of dynamic content groups implementation of integration of CDS hooks into our environment. So it starts off with a CDS hooks request with patient data. This would just be a JSON structure. We'll get more into detail on these. This is just a brief overview. And that would be sent into our clinical reasoning implementation, which would then fetch the associated plan definition, right? And that associated plan definition would reference CQL libraries that would provide logic for this guideline. And then we would run that through FHIR's defined apply operation, which would go through the CQL libraries and execute the criteria or expressions and give us back results, which then we can either move on to subsequent actions or give suggestions, things like this, which would then be returned into a care plan, which would then be converted to a CDS hooks response card. So that's just a basic overview. So let's get a little more into CDS hooks. So a CDS hooks discovery is just an endpoint that allows CDS clients to figure out what services are available what services are available and how to call them and what information should be provided to them. Right? For example, here's a very simple service call, which we have a couple here. One is a patient view hook. We provide a title and description, and then the important part there is the ID and the prefetch. And the prefetch is very important as it gets back to the speed challenge for implementation. So CDS hooks provides this mechanism, this prefetch mechanism, that allows the caller to provide the information instead of requiring the system itself to call back to the FHIR server to get the information, which can be very expensive, especially if there's terminology involved, as that could lead to a large amount of HTTP calls, which would make that half-second response time near impossible to meet. Right? So, and the way to call these operations are just the CDS discovery endpoint / the ID. Right? And then once you call that, you will get back and then you would be able to form your CDS hooks request. And that's just these elements over here. The important parts are the FHIR server. For one, this would be where the patient data would live. And then we would describe the hook. There's a few predefined hooks in CDS hooks at the time. Currently, one is patient view, which would basically be like an open patient chart. It runs some kind of CDS, right? And then we have FHIR authorization, if it's an TLS connection or anything like that, or we need security. This provides bearer tokens or anything like that. And then along with context data. So this is the user ID, the person using the service, along with a patient ID, which is the patient we're running the service on, and then the encounter ID, which is just the encounter where this action took place, right? And then we include our prefetch data. For this is just a simple patient. And we'll actually dig a little bit more into this later as well. And then after that's all done, we'll get back our CDS hooks response, which is just a set of cards which contain decision support from the service. So this would be typically in the form of perhaps a little bit of guidance or an action that needs to be taken by the clinician, like creating a medication request or some other thing like that. And we'll also dig into this more as we go into our real-world example of the CDC opioid prescribing guidelines. So recommendation 5 is the one we're going to take a look at. And as you can see here, it's just to prescribe the lowest effective dosage of opioids. So providers should use caution when prescribing opioids at any dosage, right? And whenever the dosage is greater than or equal to 50 MME, then they should avoid that. And if it's greater than or equal to 90 MME, then they should avoid that immediately. That's very dangerous, right? So there are 2 conditions that must be met for this patient before this is called, one of which is that the patient is being prescribed opioids for chronic pain. The other that the patient does not appear at end of life. And then Our responses to that would be if the MME is greater than 50 and less than 90, provide recommendation to taper, and then if it's greater than or equal to 90, then taper immediately. And there are a couple of implementation challenges associated with this. One is that chronic pain is pretty difficult actually to infer. It's not easy just, you can't just check a box. It's chronic pain. We usually have to determine that in our workflow. So typically it's appropriate, and the way we tackled it was to say if a patient is taking an opioid for 80 of the past 90 days, we'll consider that to be chronic pain. Right? And that may be incorrect, but it's the best we could do. So the next one would be patient does not appear to be at end of life. Again, it's not easy to infer that. One way is to say, is the patient not in hospice care? All right, then they're probably not at end of life. That could be wrong too, right? Does the patient have cancer? Right, and maybe we want to, maybe a better way would be to define a value set that would define conditions that indicate end of life care. But then we have to get, consensus from terminologists, which is impossible, and to actually define that concept, right? So MME is another difficulty. It's a very difficult calculation to implement, and again, difficult to get clinicians to agree on the proper calculation. So again, we're just reiterating here what the responses would be, and the provider is also presented with options to change the dosage, or to basically just snooze on the recommendation because either the benefits outweigh the cost, or the risks, or there's acute pain, or it's just not applicable and they give a reason why. And then here's just a basic functional diagram that goes through, the decision points for this guideline, which is, is the patient prescribed with opioids with ambulatory abuse potential? Right? If that's true, then we move on to, is there conditions indicating end of life? If that's true, then we move on. Has the patient been prescribed opioids for 80 of the past 90 days? If that's true, then we calculate the MME and provide the response, and then we give the clinician a decision point there, which is a little circle with the cross on it, which they will decide one of those 4 options. Right? So this is the basic workflow for recommendation 5. Okay, so let's take a little field trip here. Ooh, I can't see that. Where'd it go? Okay. Sorry about that. To go over. There we go. Okay. So this is the opioid prescribing support implementation guide. For those of you that aren't familiar with implementation guides, they're quite common in FHIR, just to provide documentation on how to implement some type of use case or idea or basically anything. For this one, it's how to implement the CDC opioid guidelines. Right? So we already went through these basic functional descriptions and diagrams. So let's take a look at a plan definition for these guidelines, just to see what these look like and walk through it a little bit. So the first thing we'll notice here is the type of plan definition we're operating on. In my case, I've typically been involved with ECA rules, which are event condition action rules, right? Which is there's a triggering event that leads to some condition that if it's true, it triggers some action, right? And then the next thing we'll notice as we move down is this library. So this library reference is to the library that actually holds the logic that will be referenced in this plan definition. Right? So as we go through these actions in the plan definition here, we will have a trigger, right? And this is just the hook that actually triggers this plan definition. And in this case, it'll be order select. Medication prescribe is what it was previously, but that's been deprecated since. And then we'll have some kind of condition here. And this condition is the total MME greater than 50? And then we have an expression. And this expression references an actual expression within the CQL, right? And this will be run or executed, and if it executes to be true, then any subsequent actions will be executed as well, right? Or any dynamic values will also be executed. And dynamic values in a plan definition can be reference to activity definitions that create, medication prescriptions or, any type of FHIR resource, basically service definitions. And, or they can just reference, again, another CQL expression that will be evaluated, and the response will populate something in the care plan that is generated by this plan definition, right? And then propagated into the CDS response. And so you'll notice here these 4 expressions: inclusion criteria, get summary, get detail, and get indicator. And then we'll have the 4 actions for the clinician to respond to, right? So this would typically be accessed through some kind of smart on FHIR app or something like that. Yeah?
Are the dynamic values inputs or outputs to the logic that's being evaluated?
Right. So the dynamic values are they just point to the CQL expression, which when it's run, it will populate some field in the output. Right. Okay, so let's take a look now at our library here. So this is just a narrative for a FHIR library here. FHIR libraries contain data requirements, which are just basically the data retrieval in the logic, typically associated with some kind of code filter or date filter. Code filters are typically value sets, and then we have a path. So, we're looking for, as you can see on that first one, we're looking for medications requests where the medication is within ambulatory abuse potential value set, right? And then here we have our actual CQL content. And as you can see, we have our inclusion criteria, which is that first condition. And that just states that the patient is 18 or older and doesn't include any exclusion criteria, which is that the patient, is not in end-of-life care, and so on, and that, and then we will calculate the total MME, which is done here. It's quite a complex operation, so we won't go too much into detail there. But these slides will be available with resources and references to you at a later date, I believe. So if you're interested in that, I will include some references to that. And then we have our 3 dynamic actions here, which are get indicator. So if this condition is true, then we give a warning, right? And then we have a summary that says, this patient's at high risk for opioid overdose. Either taper now or, consider tapering. And then we give our detail, which is the actual result of the MME calculation, along with guidance to taper. Right. And then, so let's look at this here. So we have a couple example requests. So in this first one here, we're looking at a patient that's 18 or older that's been prescribed fentanyl a fentanyl patch, 3 days for 30 days. This will trigger the message, high risk for opioid overdose, taper now, and then it will link to MME conversion tables, right, to give additional feedback to the clinician. So this includes a bundle of patient data that would be expected to be provided, along with a request here. So let's walk through this. So our request is pointing to our FHIR server. For this, we're just pointing at a local server for testing. We're defining our order select hook here. This is actually a proprietary thing. It's not part of the CDS hook spec. But for testing purposes, it's actually quite difficult to maintain test data for CDS operations, as they typically need the information to be, dated today. Like it happened right now. That's difficult to do with patient data. You don't want to have to go through every time you run it and update all the dates and stuff. So we've implemented some extensions on our FHIR resources to define some elements as CQL expressions that run, so it's basically dynamic test data that runs CQL within it to populate dates. That's basically what that does. Sorry, that was a bit of an aside there. And then we provide our context here. So just basically outlining our practitioner, our patient, and our encounter, and then identifying our context medication request here. So this is the medication request for fentanyl. As you can see here, this expression, this is the apply CQL expression that states today. And then we provide our prefetch down here, which is just a simple patient resource. Right. Oops. All right, and when you run that, the expected response you should get back from the service should look something like this. So you should get back a card that says, this patient is at high risk for opioid overdose, taper now. It's a warning. And then it says the total MME is 179 and taper to less than 50. So this patient would be at extreme risk, obviously. And then we provide our source, which would be the CDC guideline for prescribing opioids website that defines all these guidelines. And then we would also provide a link to the MME conversion tables. Okay. So are there any questions on that? Pretty straightforward. All right. Oh, yeah, I gotta go this way. All right. I guess I went through that a little too quick. That's actually all I have at the moment. Yeesh. All right. Well, sorry for the brevity there.